So Dr. Deborah Rabinovich is going to be presenting next. Deb graduated from the University of Ottawa's Faculty of Medicine in 2005. Following residency at University of Toronto, she did an EMG fellowship at the Sunnybrook Health Sciences Centre. Deb now supports people living with ALS through the Sunnybrook Clinic every week. If you guys can please welcome her to the stage.
Thank you. So as you mentioned, I'm a physiatrist in the ALS clinic, and I generally, can everybody hear me? No? Deal with issues of general functioning and particularly spasticity. During today's talk, we're going to talk about the definition, the etiology, the pathophysiology, how we evaluate patients with spasticity, the functional impacts, treatment, and then we'll summarize at the end. So the definition of spasticity is essentially a velocity-dependent increase in muscle tone that's part of the upper motor neuron syndrome. The upper motor neuron syndrome also is composed of weakness, hyperreflexia, upgoing plantar responses, and clonus. Spasticity can essentially be caused by any lesion within the central nervous system. This can include an infarct, a hemorrhage, demyelination, or motor neuron disease. So basically, it's caused when there's a lack of suppression of hyperexcitability. Usually the muscles contract, and if there isn't sufficient relaxation of the muscles, then the muscles become very rigid. Suppression is typically accomplished by both pathways from the cerebral pathways and spinal mechanisms. We evaluate spasticity using predominantly two different evaluation tools, the modified Ashworth scale and the Tardeu scale. The modified Ashworth scale has very good intra-rater reliability, and the Tardeu scale is used more often for Botox injections and evaluating the improvements secondary to Botox. So basically the modified Ashworth scale is rated as 0 if there's no increase in tone, a 1 if there's a small catch, 1+ if there's a mild increase in tone through less than 50%, and 2 if there's mild increase in tone for greater than 50%. 3 means that there's moderate increase in tone diffusely, and a 4 is the muscles are very rigid. And the Tardeu scale, like I said, is often used when using Botox to inject the muscles to see if there's been an improvement, and it typically is the difference between the catch angle and the angle of a slow range of motion. So spasticity can be defined into focal, general, and regional. Focal generally meaning that it affects a specific area or specific limb. General meaning that it affects kind of the whole body, or regional where it affects a moderate distribution of the body, such as the upper extremities, the lower extremities, or half of the body. So spasticity can have grave effects on patients. Basically, this can impact the ability to bathe the area. It can impact mobility. It can cause skin breakdown. It can impact being able to grasp or reach for things. It can cause pain or sleep disturbances, and sometimes people become depressed. It's also important for seating, such as in wheelchairs, or fitting orthoses. Sometimes people can't fit into like specific ankle flexion orthoses because of their spasticity. So here, upcoming are just a bunch of pictures of kind of typical postures that we see in spasticity. So one of them is like a thumb stuck in the palm. And this essentially impacts the ability for people to grasp objects. It also it can lead to skin breakdown. We also see a clenched fist, which similarly impacts your ability to grasp. It impacts the ability to clean and can lead to kind of noxious smells and can lead to skin breakdown. Often we see a flexed wrist also, which makes it very difficult to dress and get your hands into long sleeve clothing. And a shoulder adducted positioning where the shoulder is up against your body is very common. We see a lot of shoulder pain secondary to this, and this also impacts your ability to reach out and grab things. Equinovarus foot, where the foot is kind of down and inwardly rotated, impacts the ability to fit into orthoses. So we often use ankle flexion orthoses, like I said, for mobility. They can't fit into these. And they also don't really have a platform to stand on during stance phase. Striatal toe, we actually don't see that often, but sometimes in ALS where the toe kind of comes up, the great toe, and this impacts the ability to fit shoe wear. So the goals of spasticity are essentially to improve mobility, to decrease pain, to increase range of motion, improve fitting of orthosis, improve positioning, and to prevent contractures. So treatment focuses on prevention, so trying to improve mobility and range of motion, non-pharmacological therapies, pharmacological therapies including oral medications, Botox, or Baclofen Pump. Oral medications and the Baclofen Pump are typically used for more diffuse spasticity, and Botox is typically used for more focal spasticity, where there's a specific treatment goal in mind. So prevention is accomplished by doing daily range of motion exercises, proper positioning, and by trying to prevent noxious stimuli, because these have been shown to increase spasticity. So things like urinary or bladder retention, pressure sores, any pain, DVTs, these can all lead to an increase in spasticity. So from a physical standpoint, we try to work on cold has been shown to decrease spasticity, and just generally stretching, range of motion exercises, using serial casting and arthroses. So we found that this isn't done very often in the adult population. However, with the kids at like Blurby Macmillan, this is very frequently done. From a pharmacological standpoint, like I previously mentioned, there are oral medications, Botox, and the Baclofen Pump. The oral medications that we typically use in the ALS patients have been Baclofen and Tizanidine, primarily because these are the ones that have been studied the most. All of these medications lead to kind of side effects that include sedation or increase in weakness. Baclofen does lower the seizure threshold, so it's careful. You have to be cautious not to use it in patients with a history of seizures. And you also have to be very careful to tell patients that they need to titrate it down slowly, because if it's terminated quickly, it can lead to seizure activity. Tizanidine and dantrolene, which are also the other two that are used, can lead to transaminitis, so increase in liver enzymes. So we need to monitor those patients. I typically start patients on Baclofen, and if they tolerate it, we try to increase the dose. If there's still issues of spasticity, we can add in other medications, and they can be used individually or kind of in combination with one another to create a synergistic effect. Baclofen Pump is something that is just new to Toronto. We actually did not have anybody that was inserting them until about 3 or 4 years ago, and now there's a surgeon at the Western that does them. We just recently sent our first patient for a referral and is considering getting one. The advantage is that you have less side effects, and it has a more steady release of Baclofen throughout the day. But once again, this is typically used for patients with very generalized spasticity. Botox, as I previously mentioned, is used for very focal spasticity, usually with a specific treatment goal of being able to fit in orthosis or being able to be seated in a wheelchair or specific issues of pain. So basically, Botox works by inhibiting what's called the SNAP25 docking protein. And what that essentially means is there's acetylcholine within the nerve terminal, and basically it prevents it from being released. And you need acetylcholine to be released in order to cause muscle contraction. So by inhibiting it, you essentially decrease muscle contraction. This medication kind of starts to work in about 24 to 72 hours after it's injected. Peak effect is in about 4 to 6 weeks, and it typically lasts for about 2 to 6 months. One of the limitations is that you can only inject it every 3 months, because if you inject it at an increased frequency than that, it can cause antibody formation, and then the medication will no longer work. The side effects include localized infections, bruising, local swelling, antibody formation, as we previously talked about, and compartment syndrome. Surgery is the last option. It's actually not frequently done in Toronto, but it is done more commonly in Western or in London, where they offer muscle lengthening and tendon lengthening procedures, as well as tendon transfers in order to achieve different contractions. So basically, in summary, spasticity is a velocity-dependent increase in muscle tone that's part of the upper motor neuron syndrome. It may cause pain or limit functioning, and it's usually treated by prevention, including physical stretching and serial casting, oral medications, particularly Baclofen, Tizanidine, and sometimes dantrolene. Baclofen Pump can also be considered for a more generalized approach, and Botox for very focal spasticity. And that is the end. Does anybody have any questions? Okay, so that's it. Thank you.